And it's also a pleasure to be here because I learn most from patients, and I'm still learning to this day, and I don't think I'll ever stop learning until the day I fit in a little box that goes on the ground. And that's what I enjoy doing, learning, and it's a learning process together. I'd like to repeat what Alice said, which is it's really important that you join your association and that you get your friends and families too. There's a very common disorder. You have strength in numbers, and it's amazing what the UK Parkinson's Association has managed to do for both patients and families with Parkinson's disease, and I'm sure that can be repeated and perhaps even bettered on in a small country like Malta, where it's so easy to communicate and to get together, rather than a big country like Great Britain or a big island like Great Britain. So onwards and upwards. The reason for me being here is really to talk about surgery for Parkinson's disease, and the subtitle of that is What Every Patient Should Know. So this talk is really aimed squarely at patients, and I'm going to try and reduce the complex medical terminology as much as possible. And if there are any professionals in the audience, well, figure it out. And if I'm saying anything that you don't understand, put your hand up, stop me, and I'll try and make that even more basic if I can. All right? So I'm a neurosurgeon, and traditionally, neurosurgeons deal with problems that affect the structure of the central nervous system, of the brain and the spinal cord. And these are a few of the patients that I've operated on over the couple of decades that I've been doing neurosurgery. And you can see a patient with lots of tumors, a patient with trauma where they've broken their neck, a patient with a blood clot pressing on the brain. And the whole idea of a neurosurgeon is to restore the normal structure to the brain, take away the blood clot, take away the tumor, fix the trauma. And these are often life-threatening conditions. It's technically challenging and demanding to do these operations, and patients, it's a life or death situation. In some of these patients, if you don't do the operation, that patient is likely to die. And therefore, the risks of surgery, which are never zero, but one can accept a 2 or 3% risk of mortality if, for example, you're clipping an aneurysm, which is a burst blood vessel inside the head, because if you don't do that operation, there's a 50% chance that that patient's going to die. What I'm going to talk to you about today is an aspect of functional neurosurgery, where we're doing an operation not to change the structure of the brain, but to change the function of the brain, how the brain processes information. So, for example, in Parkinson's disease, the brain looks practically normal. If you were to do a scan of a patient with Parkinson's disease, there's nothing grossly abnormal about that. But we know that the functioning of that brain isn't as it should be, giving rise to the symptoms of Parkinson's disease. But people do not die of Parkinson's disease, and therefore a 1% mortality from surgery from Parkinson's disease is not acceptable. We're not allowed, we shouldn't be able to take risks with patients' lives, as we do perhaps in other forms of neurosurgery. So because we're trying to improve quality of life, the main aim, or there's a heavy emphasis on safety. So this is just a video of a patient of mine in England, and you can see before surgery, you can see that he's got all the hallmarks of Parkinson's disease. He's got slowness of movement, difficulty walking, and then after surgery, you can see that he's got some restoration of independence. He can walk without help, without assistance, and that slowness of movement is a lot better. And this is a patient off medication both before and after surgery. So to give you a brief overview of what we're going to talk about today, I'm going to spend a few minutes talking about what is Parkinson's disease. It's important to understand what we think is going on, that you as patients and as families understand what is going on. We'll talk a little bit about how surgery for Parkinson's disease developed, because many people think that this is a new development. It isn't. It's over a century old. What does the surgery involve today? And those are new developments. How we do the surgery is very different to how the pioneers of functional neurosurgery did surgery 100 years ago. We'll talk about the modern risks and benefits from surgery, and we'll also touch a little bit at the end on what new avenues, what potential therapies are being explored in the world of research. So what are brains? Brains are beautiful things, and they define who we are. Our brain is who we are. It gives us our thoughts, it gives us our feelings, it gives us our movement. And in fact, it's such an incredible thing that, as you know, the brain has cells, and there are connections between cells, and the number of connections in every single brain in the room outnumbers the numbers of stars in our galaxy. Right? It's the most incredible thing to think about. The problem is that when you have an illness that attacks the brain, it can affect our movement, it can affect our mood, it can affect our thoughts. And because it threatens that identity of who we are, it's a very stressful thing for people who have the illness and for the families who are affected with their loved ones. And thankfully, over the decades, clinical neuroscience has learnt a lot. That process of scientific exploration and endeavour has meant that we have a lot to offer to patients and families with Parkinson's disease. But it's important that you're informed as to what is available. There are no cures for Parkinson's disease. We are striving in terms of research towards that, but that's a long way away. But until then, there's a lot we can do to help with the symptoms of Parkinson's disease. So what actually goes wrong in patients with Parkinson's disease? Well, the first thing to say is that Parkinson's disease is a neurodegenerative disorder. What we mean by that is that for some reason, nerve cells within the brain and throughout the body start to malfunction and start to die. And we think that the reason for this is that there's a protein called alpha-synuclein. The name isn't important, but a protein is a long string of amino acids. And the problem is not that the protein is abnormal, but it starts to fold abnormally. So it's like you have a chain, and instead of having one shape, for some reason, it starts to take another shape. And when it takes this shape, instead of being what we call the alpha form, it forms the beta form. And this beta forms clumps or sheets. And this protein starts to clump together, and it starts to accumulate in cells. And as this protein accumulates, it forms big clusters inside the cells that are called Lewy bodies. And for some reason, when one neuron gets infected in this way or gets affected in this way, it can transmit this abnormal folding to nearby neurons. So this process is a slow process, and it tends to spread throughout the nervous system. What happens in these nerve cells that have this abnormal protein structure inside it is that this interferes with mitochondrial function. Mitochondria are like the dynamo, the energy house of each cell. So each cell needs energy to live and to do its job, and as the energy output of the cell decreases, that cell finds it more and more difficult to do the job that it should be doing. And eventually it doesn't have enough energy, and eventually they can die off. And this especially affects cells that have high energy demands. So we have billions, trillions of cells in our bodies, but some cells need a lot of energy to do their job properly. And little cells in the substantia nigra, which means the black substance of the brainstem, as you can see here, this is a cut through the brain around the level of the ear. And in the brainstem, there's this little structure called the substantia nigra. And in patients with Parkinson's disease, that black stuff, that's what substantia nigra means in Latin, disappears. And it's that black stuff that produces a chemical known as dopamine. And therefore, the level of dopamine within the brain tends to drop, tends to fall. We don't have enough dopamine within the brain. And this process affects nerve and brain cells throughout the nervous system. But the process actually doesn't start in the brain. It starts in the gut, in the nerve cells in the intestine, and in the nerve cells that we have in our nose. And it only very slowly moves throughout the nervous system, first through the brainstem, and then throughout the whole of the cortex, which is the covering of the brain. But the brain and nature in general is a resilient thing. And you don't get any symptoms until you've lost 70% of those dopamine cells. So the brain's fighting back. The brain's trying to do a good job. But at some point it loses so many of those cells that it fails to keep doing everything as perfectly as it was before. And we develop what are called motor symptoms. When the levels of dopamine reach a critical point, people start getting a variety of symptoms. And the best known, if you like, in the general public is tremor, right? This sort of pill-rolling tremor which occurs at rest. But you also get slowness, what doctors call akinesia or bradykinesia, or stiffness. And many people present with pain. The first motor symptom they have is pain. They don't say, I've got a stiff muscle here, doctor. They say, oh, my back keeps aching in the morning. And these are subtle signs. You can get problems with posture. So instead of standing straight, we start to bend forwards a little bit. Speech can become more slurred or hypophonic, which means low volume, and it becomes a bit more difficult to understand what people are saying. And another frequent way of people presenting is handwriting. People's naturally nice round handwriting becomes a little bit spider-like and crawly. So these are different ways in which movement can be affected. And the interesting thing, if you like, is that no two people are exactly identical. Different people present in different ways. So when we say Parkinson's disease, there are some people who have a lot of tremor and hardly anything else. There are some people who have no tremor, but they walk very slowly. There are some people who have no tremor, have no slowness, but have a lot of stiffness and rigidity and aches and pains. So everyone experiences the symptoms of Parkinson's disease in a slightly different way. And the truth is, you remember we said that you can lose up to 70% of those little black cells in your brain before you get motor symptoms. The truth is that the problem is a lot bigger than what we're seeing at the surface, just like the iceberg. And the disease can start several decades before you actually get any symptoms. And because it's the gut cells and the smell cells that are affected first, constipation and decrease in smell can actually predate the motor symptoms by many years, sometimes even 10 or 20 years. But these symptoms appear gradually. And when things happen slowly, it's very difficult for you to notice. We're getting on with our lives. The fact that things don't smell as strong as they did 10 years ago, that doesn't really hit us in the face. It's only when you start seeing the shaking or the aches and pains that you pay attention. And these non-motor symptoms don't just occur before the motor symptoms, but they can get worse after the motor symptoms. And in fact, a lot of people with Parkinson's disease can suffer from low mood, from depression. Dopamine is the chemical we have in our brain that makes us cheery. Whenever you feel good about yourself, you get a rush of dopamine in the brain. If your brain is struggling to produce that dopamine, then you may have a low mood. You can have interference with sleep. You don't get a good night's sleep, right? So these are not the classical signs of Parkinson's disease when you think about that in the textbook, but they are things that can bother patients and can interfere with family life. So just some facts about Parkinson's disease. It's a common disorder. It's the second most common neurodegenerative disorder, those sort of disorders that affect cells that make them die prematurely, after Alzheimer's disease. And in fact, Parkinson's disease becomes more common as we get older. So the chances of any one of us developing Parkinson's disease when we're 70 are much higher than when we're 50. And over the age of 60, around 1 in 100 people suffer from Parkinson's disease. So that's pretty common. You may have read a lot about the genes in Parkinson's disease and whether genes can cause Parkinson's disease, and it's very clear that it can. If you have some problem with a particular gene, it can bring on a type of Parkinson's. But this is very rare. Only about 5 in every 100 patients with Parkinson's disease has one gene as the cause of that. And when that's the case, it usually means that your symptoms of Parkinson's disease start quite early on, maybe in your 40s or 50s, rather than later on in life, which is what most patients with Parkinson's disease start the symptoms. So the majority of patients with Parkinson's disease, the cause is a combination of environmental factors, what we call non-genetic factors, interacting with a number of genes that come together that we're born with to give us the chance of causing Parkinson's disease. And the truth is, we don't know what all those factors are. And a lot of the studies that doctors and epidemiologists do is to try and understand that better. There's a possible effect of protection with smoking and with coffee drinking. But that effect is very, very small. And in fact, I would discourage you from smoking because the chance of your getting lung cancer is much higher than the protection of not getting Parkinson's.
What about alcohol?
Say again?
What about alcohol?
So there's been a lot of studies about alcohol. The jury's still out, and the evidence is not there. So it's not a risk factor or a protective factor. Yes?
Is Parkinson's hereditary?
So what I was trying to say in the last slide is that there are some rare forms of Parkinson's disease that are hereditary, but only about 5%, 5 in every 100 forms of Parkinson's are strongly hereditary. And it's usually in patients who develop Parkinson's disease very early on in life, for example, in their 30s, 40s, or 50s. So the bottom line is if you have a relative who's developed Parkinson's disease in their 60s, your risk as a relative of that patient, right, is no higher than the risk of the rest of the population. But if you're a direct relative, the son or daughter, of someone who has developed Parkinson's disease when they were 35 or 36, then there's a chance, a good chance, that that could be a strong genetic element. And there are facilities available, even locally, to do genetic studies to see whether you have transmitted that or what the risks are of transmitting that gene to your children. But if your relative is over the age of 60, there's no point in doing genetic tests. And the question from the back.
Can Parkinson's be caused by a head injury?
That's a very good question. We know that repetitive head injury, like boxers, right, can develop a type of Parkinsonism. So Parkinson's disease, like we said before, has many different types. It's not one disease. People have tremor, people have slowness, people have... But Parkinsonism secondary to head injury is slightly different from Parkinson's disease and doesn't always respond to the same therapy. If you're asking whether the form of Parkinson's disease that we generally look at, or at the commoner form of Parkinson's disease, there's no evidence that head injury plays a role in that. So the problem with that sort of study is that if I don't develop a disease, a cranial disease, and I've hit my head when I was 19 playing rugby, I just forget about it. But if I develop, I don't know whether it's Parkinson's disease or dementia or some other problem with my brain, you look for a reason for it, and you remember that rugby accident you had when you were a kid, or when you fell over and cracked your head on the pavement. So there's that sort of selective recall bias. So the answer to your question is no, there is no evidence.
Can Parkinson be related at all with cardiac problems?
There is what we call a vascular form of Parkinsonism. If the blood supply to the brain is not good enough, then those dopamine cells can die for a different type of reason than the Lewy bodies that we mentioned before. And you can develop some of the symptoms of Parkinson's disease, but we don't call it Parkinson's disease. We call it Parkinsonism. So you can develop some forms of Parkinsonism, some of the symptoms of Parkinson's disease, because of blood vessel problems to the brain, but that isn't strictly speaking Parkinson's disease. We call it vascular Parkinsonism.
You consider for not finding the right word to say a symptom of Parkinson, as you said, the
looking for the right word.
Yeah, and it seems that
that would be a very, very unusual symptom of Parkinson's disease. Later on in the disease, after somebody may have had the disease for 30 years or so, then it can affect that sort, but not at the beginning. Hello.
You mentioned symptoms.
Yes.
Is there any kind of test to check if you have Parkinson's when you are so young?
That's a very good question, and doctors are looking at that in a great detail. If you are at risk of developing Parkinson's because there is a person with the genetic form of Parkinson's who's related to you, one can do genetic tests, right? But that is, even if you do have the gene, that doesn't mean you will definitely develop Parkinson's, it just means your risk is higher, right? So there's something called penetrance. So a gene can be there but never gets expressed. Neurologists are developing smell tests, because remember, one of the first symptoms is a lack of smell. So there are some smell tests that you can do if you're worried about developing Parkinsonism or Parkinson's disease, and if your smell isn't as good as it should be for the population, that may tell you you're at increased risk of developing Parkinson's. But there's no one test that you can do to say, I am going to develop Parkinson's disease, or I'm not going to develop Parkinson's disease. The best test is what we call a PET scan. where you actually give a radioligand, that's a molecule which is radioactive, and you do a PET scan to see how much dopamine you have in your brain. And because the levels of dopamine start going down before you get the symptoms, right, this is one test you can do. The problem is, at the moment, we don't have any therapy or treatment to change the course of what's going to happen. And there are many people who may have lower dopamine levels, but because it's a slow process, they never actually develop the symptoms. So you end up with knowledge that you can do very little about, which just makes you stressed and doesn't have any positive value. So I would discourage people from going down that line at the moment, although there's a lot of research looking at populations of patients to try and see whether we can answer that question. There's nothing that can be done on the individual level. Does that answer your question? So just so you understand the history of Parkinson's disease a little bit, this chap here is James Parkinson, and he described the shaking palsy in 1817. He was the first person to ever describe the symptoms of Parkinson's disease. However, it turns out he wasn't a doctor. He was a surgeon. And you may know that surgeons call themselves, high level, surgeons call themselves Mr. These days, surgeons are doctors, they qualify as doctors, and then they do their surgical training, they call themselves Mr. And the reason they call themselves Mr. is that back in the 1500s and 1600s, the doctors learnt all their anatomy from a book that was written 100 years after Christ, right, which was full of errors. Whereas the surgeons were the barbers, who were also the butchers, who learnt their anatomy from the animals, right? And the surgeons learnt their anatomy by dissecting cadavers, dissecting people. So the surgeons actually formed a Royal College of Surgeons in 1500s in the UK, up in Edinburgh, and they looked down their noses at the doctors because they knew their anatomy much better than the doctors did. And to this day, 500 years later, we call ourselves Mr. because we're not as bad as the doctors, right? But it's interesting to think that the person who described the symptoms was not actually a doctor. His father was a doctor, but he was actually a surgeon. He never qualified as a doctor. The problem also is that that face, if you put Parkinson's disease into Google, that will come up the first few images. The problem is that he died, James Parkinson, died in 1824. And the first photograph that we've ever made was in 1826. So that's clearly not a photograph of Parkinson unless they did a really good job embalming him. Right? So we don't have a picture of Parkinson. We don't know what he looks like. Now, the truth is that surgical therapies for Parkinson's disease were developed in the late 1800s and were actually done in the very hospital I'm working in London. And the first neurosurgeon in the world, called Victor Horsley, was looking after patients with Parkinson's disease with very bad tremor. And what he would do is actually take out the part of the brain that moves the arm. He would make them paralyzed. And the patient said, "Thank you." This is how bad, this is how desperate things were in the 1890s. But it was a start, because that continual jerking, the fact that they were paralyzed on one side meant that everything wasn't moving and they could use their other hand. So this is how desperate things were at the time. And the problem was, it became the dogma, because sometimes doctors suffer from dogma as well, that you could not help a movement disorder without causing weakness and paralysis. Until this chap came along. And I don't have idols, I don't put people on pedestals, but this chap is worthy of note. Irving Cooper was a neurosurgeon in the States, and he was doing an operation on a patient with Parkinson's disease who had very severe tremor. And he was doing a refinement of the operation we spoke about before. Rather than taking out the cortex, the part of the brain that controls the hand, he was opening the base of the brain and cutting the fibers, the nerves that went from the cortex to the spinal cord and then to the arm. But on his way in, before he could cut those fibers, he damaged a very small blood vessel. And he couldn't stop the bleeding. He just couldn't. And he put a little silver clip across it. He occluded the artery. And of course the brain, if you occlude the artery, a part of the brain is going to die. And instead of going on and cutting the fibers, he said, well, I think the part of the brain that I damaged may actually help this patient. He knew a bit about the brain, so he abandoned the operation. And to his delight, the patient woke up without tremor and without paralysis. In other words, he'd done a lesion of the brain, a different lesion than he wanted to start off with, and the benefits were positive. And I've dug up a video of the second patient that he did on purpose, and this is it. And this is a patient with Parkinson's disease. You can see he needs the help of a nurse to get out of the chair. But then after the surgery, he can get out of the chair on his own, and you can see that he's moving his arm on the left-hand side, because the operation was done on the right, and he's got the arm swing back on the left, on the opposite side. You know that this part of the brain controls this side of the body and vice versa, right? So this was what we call serendipity, right? This was a lucky stroke, and he didn't say, that's fantastic, I'm really happy for the patient, off you go. He went to the lab, he tried to discover where that little artery goes, and he realized that if you make a lesion, right, if you destroy a small part of the brain in the depths of the brain, called the basal ganglia, you could help movement disorders without causing paralysis. And the doctors at the time mocked him. They said, you can't, everyone knows that you can't cure a movement disorder without causing weakness. And he persisted. And this chap operated on almost 8,000 patients in 10 years. Right? I don't think I can... I'm about to reach 800, and I've been doing this for 10 years now. So the way to reach that deep area, the basal ganglia, with extreme precision, because you want to damage that part of the brain that stops the tremor, but you don't want to damage parts of the brain that make you weak, they used a technique called the stereotactic technique. And the stereotactic technique was, again, another discovery of Horsley, Horsley being the world's first neurosurgeon. And again, I'm lucky to work in the same building that he worked in more than 100 years ago. But he never used this stereotactic frame on patients. He only used them on primates, on monkeys. And the stereotactic technique is very easy. If I have a map of London, and I give you a map of London, and I tell you, well, I want you to go from A to B, it's very difficult to describe go from A to B until I put a grid on the map. Once I put a grid on the map, I can then say, I want you to go from square A1 to square D5, right? So having a picture of something is not very helpful in navigating, but having a picture and putting a grid on it makes it very easy to navigate. And if you take a picture of the head with a grid on it, which is this frame, then that makes it much easier to navigate with extreme precision. But it took an American neurologist, this is Spiegel, and an American neurosurgeon, Physis, to transfer this technology, right, because this was the technology of the age, right, this cutting-edge technology, to humans. And they did this in 1947. And what they did is, instead of clipping arteries, which is a bit random, because different arteries can cover different parts of the brain in different people. So when you clip an artery, you're never quite sure what's going to live and what's going to die. But if you put a probe into the brain, and you make a little, and you heat up the tip of that probe, you can damage a very precise area of the brain. So they replaced these vascular lesions with a thermal lesion. And you can do it in a minimally invasive fashion. You don't have to open the head and lift the brain and find the blood vessel. You can make a very small hole in the skull and go with extreme precision to that spot in the brain. So this traditional approach to functional neurosurgery was performed in the 50s and the 60s, and thousands, no, tens of thousands of patients had this sort of surgery. So surgery for Parkinson's disease is not new, okay? The problem is these pioneers didn't have the technology required to see the area of the brain they were trying to hit. The only thing they had at the time were X-rays and a frame, and they used to inject air into the brain so that the air provided some contrast. It was very difficult for patients to go through this. And they used atlases so they could have a guess of where they wanted to go in the brain. And the only way that they could tell that they've reached the right spot was to do surgery with patients awake, under local anesthetic. And when they reached the right spot, they would tell the patient to move their hand, the tremor would go, and they could move their hand. Whereas if they were in a spot where the tremor went away but they couldn't move their hand, well, then we shouldn't do the lesion there. And they had to explore the brain with multiple tracks until they got it right. So these were exceedingly courageous surgeons and even more courageous patients, right? So what we know today is built on the massive work that these people did in the 50s and 60s. Function neurosurgery died a death. It died in the 1970s and 1980s, and it died for one main reason: the discovery of dopamine. And those of you who are in the room who take your Cinemet and take all the other dopa agonists like ropinirole that you're on, right? That wasn't available until 1969 at the very latest, right? So that's not very long ago. And in fact, my father, who's sitting over there, didn't train in functional neurosurgery because when he was training in neurosurgery in the UK, this wasn't done anymore because we had this magic pill called dopamine. And it was brilliant. Why on earth would you do an operation if a little pill can help? And they're absolutely right. The problem is, we now know that after 5, 10 years of taking medication, you start getting problems. And the problems are that the medication works for a short period of time and then doesn't work, and then works for a short period of time and then doesn't work. Or it can work too much and you develop side effects like dyskinesias. And those of you who have Parkinson's or know patients with Parkinson's will know you get too much movement if you take too much medication. And therefore, in the 80s and 90s, when I became a medical student and aspiring neurosurgeon, we started seeing this neurosurgery creep back. People started to look at what people did decades ago and try and replicate that or try and improve on that for these patients who either could not tolerate medication or in whom medication was no longer working or where the medication was causing bad side effects. So what's the modern management of Parkinson's disease? And the first thing I'd say is keep active. If you don't lose it, you lose it. So physiotherapy is really important. Walking, dancing therapy, mental training, think big, think loud. Drive your brain to do what it can. Effective medication, and there's a lot of it. Lord knows that you guys know more than I do how much medication we have. But that's a good thing. The more options we have, the better. But also, there's this surgical neuromodulation, using surgery to change how the brain processes information. And we should only use surgery when medication isn't doing a good enough job. Okay? The thing is, we've got a lot of technological advances. Since the 1940s, 50s, and 60s, doctors have a lot of technology at their disposal. And the first bit of technology we have is that we understand how the brain works ever so slightly more than they did 50, 60 years ago. And we know that the brain has primitive circuits in it, that the neurons communicate with each other, and most of those neurons are calming the other neurons down, and some of those neurons are egging the other neurons on. So there are what we call inhibition and activation. And what happens when you lose this black stuff here, substantia nigra? What chemical goes down in the brain?
Dopamine.
Dopamine. We don't have enough dopamine. And you can think of dopamine as the oil in the machine. And when you don't have enough oil, everything grinds to a halt and gives you that slowness. And some areas of the brain, some of the nuclei, what we call grey collections of neurons deep within the brain, especially things called nuclei called the subthalamic nucleus and globus pallidus, they go into overdrive. So whereas the dopamine cells of the nigra calm down because they can't produce enough dopamine, other areas of the brain go hell for leather, and the neurons are firing all the time, much more than they should be. So what this tells us is that if we calm down those areas of the brain, either by putting a lesion there, right, or some other way of calming those nerves down, maybe we can have a good effect on the function of the brain. So this gives us an understanding that there are different parts of that circuit that we can intervene in to help patients. The second thing is we've developed something called deep brain stimulation. So we talked about the fact that we were making very small and precise holes in the brain with thermal ablation, and the results were very good. I still do it to this day. There are some patients who have a chronic infection where if you put a foreign body in their body, they will become infected and you have to take it out again. There's no point trying. And if I put a lesion in a part of the brain, then I can help those patients. But it's much safer and much easier to do deep brain stimulation if you can, because if I put an electrode in the brain and I don't like where it is, I can move it. But if I put a lesion in the brain and I don't like where it is, not much I can do about it, right? The other thing is that we said that Parkinson's disease is a degenerative condition, so over the years it tends to slowly get worse. Over the years, you can change the amount of electricity you're giving to the brain. And what we found is that when you pass a high frequency current, where you put a very small electrical impulse, 130 times per second, so that's quite a lot of electricity, isn't it? Right? You have a very similar effect to making a lesion, except that it's reversible. If you don't like the effect, you switch it off. Okay? So, the good thing about this is it's early reversible. Why do I say early? Because if I take someone who's had surgery 5 years ago and I switch their deep brain stimulation off, they are going to be so dependent on that that you can't really switch the device off without causing very bad effects. So you can't reverse it later on. Having said that, if you've got a good effect, would you want to reverse it? Probably not. The other thing is that we can record from that electrode, and we can look at the activity of the brain in living human beings in an ethical way. So it's the one way that, as on one hat I'm a neurosurgeon, on the other hat I'm a scientist. I want to learn how this does what it does. And this is a unique opportunity to explore the living human brain, right, in an ethical fashion. Just to come back to this picture, this is a picture of the electrode that goes in the brain, highly magnified. It's a bit like a very thin spaghetti, right? And at the end of it, you've got 4 little electrical contacts, right? That's where the electrical current comes out of, and you can choose which one of those you want to use. And that's connected, so that's what this is. That's connected to wires that go underneath the skin to a battery and a little computer, which is underneath the skin, usually on the chest wall. So you can think of this as a pacemaker for the brain, instead of a pacemaker for the heart. Although the skullduggery inside that, the mechanics inside that, is much more complex than a cardiac pacemaker. The third thing, and perhaps the most exciting thing and important thing, is that we now have a wonderful thing called MRI imaging. And MR allows us to have detailed images of the living human brain. So I can see what I'm operating on before I do the operation. And I can also see what I've done after I've done the operation in great detail. And this is something that my forefathers didn't have. In fact, my actual father didn't have when he was training, because my MRI scan came in the 80s, right? Deep brain stimulation for Parkinson's disease has a strong evidence base. Now, in science and in medical science, there's such a thing called evidence. So there are some people who will give you, have you heard of homeopathy? There are some people who will give you dilute water, that's what it is, just water, and tell you this will cure everything. The evidence for that is 0. If it works, it's all in your mind, right? The best evidence you can have is to do a randomized controlled trial. What do we mean by that? Where you give the therapy and you give sugar water, right? And you see if there's any difference without telling the patient and without telling the doctor who's looking after the patient. And you see whether one group is better than the other. Does that make sense? And now you're blindfolded. The patient's blindfolded, the doctor's blindfolded, so you can't influence the results of the study. And the good thing about DBS is that I can be the doctor assessing the patient, you can be the patient, and he's the researcher. And he comes and he switches the device on, but doesn't tell you and doesn't tell me. And he says, okay, assess the patient. Then he switches the device off, right, and doesn't tell you and doesn't tell me, and you assess the patient. Or the other way around. He switches the device off and doesn't tell you and doesn't tell me, right? And that way you can assess whether the therapy is actually doing something or not in a very objective and scientific manner. The biggest problem with these studies is that you can't blind the patient. It's so obvious when you switch the device on that the patient knows every time. The patient guesses right every time. Very important to notice that deep brain stimulation is not an operation, right? It's a lifelong therapy. It's a therapy that begins with an operation, but then it's given throughout your life. Just like medication. You take the medication, you keep taking it. You do the surgery, but then the stimulation keeps going, and you can adjust the stimulation over the years. And it's not just a neurosurgeon. I couldn't work on my own. I work with neurologists, and here I work very closely with Dr. Aquilina. In London, I work with 2 other neurologists who I'm very very fond of and work very well with them. And it's also important that there are lots of other people around that, including patient organisations, your GP. And it's also very important to notice that we're not treating a patient. We're treating the patient in the context of the family. And it's important to involve the family. When we first started doing deep brain stimulation, we didn't realise this. And very often, patients with very bad Parkinson's disease, their spouse becomes their main carer. And after surgery, patients can improve so much that the carer has nothing to do anymore. And if the marriage became a carer-patient relationship, sometimes when that left, so did the marriage. And the marriage would break down. So we give a lot of counselling, especially in the UK, where divorce is perhaps maybe a little bit more common than Malta nowadays, right? About how the surgery might affect not only the patient's lives, but the family's life. So which Parkinson's patients may benefit from surgery? Well, the first thing to say is that it needs to be a good diagnosis of Parkinson's disease. And as we've said, there are other related conditions. We've had vascular Parkinsonism, after head injury Parkinsonism, and there are other conditions that mimic Parkinson's disease, like multiple system atrophy or MSA, or PSP, progressive supranuclear palsy. Don't worry about the big words, but these conditions don't do well with surgery. So it's very important that you have a neurologist and a neurosurgeon who knows the condition well. There's no point operating on patients who are doing well with medication. If you're doing well with medication, then you don't need surgery. So if medication is not providing adequate symptom control, you've got these motor fluctuations where sometimes it works and sometimes it doesn't. Sometimes it works, sometimes it doesn't. Or if you've got persistent tremor, some patients, however much medication you give them, the tremor doesn't go away. Right? These patients could benefit from surgery. It's important that the medication still provides some benefit, even if it's a short amount of time. Because what surgery can achieve, if that's your day, right? What surgery can achieve is help keep you up there. But if the medication doesn't make you better, then the surgery is unlikely to make you better. Does that make sense?
Can you repeat that, please?
Of course. So when patients take medication, if they improve even briefly, even if it's 5 minutes in a day, then there's the chance that surgery can improve that much, but keep it sustained during the day. But if you're taking medication and it never improves things, then it's unlikely that surgery is going to help. And in fact, one of the things we do when we assess patients for surgery, and there are a few familiar patients in the room, is that before surgery, we will measure what you're like off medication. We'll stop your medication, see what you're like, what your symptoms are like, and then we will give you medication and see how much things improve. Because if that difference is very big, then that's very encouraging for us when we're recommending surgery. Right? If you're taking medication, they're working well, but they're giving you disabling side effects, either dyskinesias, right? That sort of movement. If the dyskinesias don't bother you, then there's no point doing anything. That's fine. But if the dyskinesias bother you, and sometimes they can be so severe that they make people fall over, or some people are just socially embarrassed about them. If they bother you as an individual, as a patient, then we can help. Other symptoms don't affect movement, but affect behavior. And there are some agonists, right? Ropinirole is one of them, where one of the side effects is to induce gambling in patients who would never gamble before. Or hypersexuality, where there's an inordinate interest in sex, even more than the Italians, right? And you might think that that's not a problem, but sometimes in the marriage it might be.
Or perhaps aggressiveness?
Aggressiveness is another dopamine dysregulation symptom, correct. So sometimes we can't continue the medication, even though they're helping the movements, because they're causing these other side effects. It's important that there's no significant cognitive compromise. Sometimes, if you've got very bad Parkinson's disease, you can start developing a form of dementia. We call Parkinson's disease dementia. And if you've got the beginnings of that, surgery might make that worse. So we also do a very detailed cognitive assessment, a neuropsychological test before the surgery, because what we don't want to do is make things worse. There's no point giving you better movement, but then your memory's not so good, or your thought processes become more muddled. That doesn't help. It's also very important that there isn't a lot of brain shrinkage on the MR. As we get older, our brain, just like our muscles and our height, tends to slowly shrink away. If there's a lot of shrinkage, then that can make the risk of bleeding in surgery higher, and it can also say that there may not be a lot of what we call physiological reserve for cognition. In other words, the way the brain works isn't very robust. Finally, if there's a contraindication to anesthesia, so if your heart won't withstand an anesthetic, or if you've got a breathing problem that doesn't allow you to withstand anesthetic, then that's something that would not allow us to perform surgery. It's very important that I emphasize this. Age is not an absolute contraindication to surgery. So I've operated on patients who are 82 in the UK with Parkinson's disease, right? Over the age of 70, there are certain operations, right, STN-DBS, subthalamic DBS, where the risks become higher. And it's a judgment call from the neurosurgeon and the neurologist as to whether that's the right thing to do. Let's face it, there are some people who are 75 and look like they're 60, and some vice versa. So it's not just the age, but also the state of good health that the patient is in. This last one is really quite essential. Patients must have realistic expectations of what's going to be achieved. This is not a cure for Parkinson's disease. Surgery doesn't make all the symptoms go away. Surgery doesn't stop the symptoms from getting worse as the years go by. It's a very powerful tool in the right patients to help those symptoms, and it can produce improvement for a very long time in patients. But if you think it's going to be a cure, and it isn't, even if you do very well, you're not going to be disappointed. I don't like disappointed patients. So when we put this electrode in the brain, we can put it in different places, right? So although deep brain stimulation is one operation, we can put the electrode in different parts of the neural circuit, the brain circuit, to help different things. And if I'm aiming for a part of the brain called the subthalamic nucleus, it's because I'm trying to help those patients with motor fluctuations, those patients with slowness, those patients with stiffness, with tremor, with walking problems. This is very useful because it helps us reduce the amount of medication. Most patients who have this operation, this type of operation, can reduce the amount of medication by about a half, right? And patients find that useful. It's very rare to stop medication after this operation. It's happened, I've operated on perhaps 700-800 patients. Maybe I've got 4 or 5 patients who've come off medication completely. So it's very rare. It does happen, but it's very rare. Usually it's stimulation and medication together that give the best quality of life. One of the downsides of this operation is that we can cause problems with speech articulation. The clarity and the volume of speech can be worse. So if your speech is already quite bad, I might think that this isn't the right target for you, and we might suggest another target. And another target is over here in the brain called the pallidum, and this is a target that's very good for dyskinesia, right, for the side effects of medication. And it's less likely to cause problems with either mentation or with speech. But it doesn't improve slowness as much as the other operation does. And finally, there are some patients with Parkinson's disease where their main problem is tremor. And this target here, called the motor thalamus, is a very good target for tremor. Of course, you don't need to remember all that. This is my job. But what I'm trying to tell you is that there are different operations I can offer to different patients because different patients have different symptoms. Parkinson's disease is not one disease. It's one disease with many different aspects. It's like a diamond in a way, right? So what does surgery look like? And this is the type of surgery that we've developed in London. And this is what I did most of my research on, my clinical research on. You remember that elaborate frame that Victor Horsley developed? This is the type of frame that we've got. Nice and clean, nice and modern. When I started doing this surgery, we were doing all the surgeries awake, with the patients awake. Now, I perform 95% of my surgery with the patients asleep, and I'll show you how we do that later. That is much more comfortable for the patient. Having said that, it's not dreadful doing surgery awake. I know that might sound strange, but it's a bit like going to the dentist. right? Not painful, but not comfortable, right? We perform an MRI scan with this frame on the head. Remember, the frame is the grid we spoke about. And then we use special MRI sequences. So the MRI, you can take different types of photographs. It's a bit like a camera where you change the aperture, change the exposure. You can fiddle with a lot of things to get the best picture you possibly can. And once we've got that picture, we can see what we're trying to aim for. And just like an archer, if you can see the target, you're much more likely to hit it than if you've got a blindfold on. So we've put a lot of effort into optimizing those pictures. And finally, we use very precise surgical instruments that look a little bit like the compasses and protractors you had in your high school sets, but a little bit more advanced than that. And we make 2 little holes at the top of the head over here to pass those little electrodes in. And once we've done that, we use an MRI scan to make sure we've hit the right spot. And if we haven't hit the right spot, we know by how much, and we can adjust that and make sure it's exactly in the right spot before we've finished. So this is a patient that had surgery when I was still a trainee, I think about 10, 12 years ago now. And you can see that she's got all the cardinal symptoms of Parkinson's. She's got the stiffness.
You see what I'm doing up here?
She's got tremor.
Copy that and make it as big and fast.
This is the neurologist, Professor Limazan, who I work with in London now. She's trying to move her hand. She's got the slowness of movement, the akinesia. You can see the slowness there. And then once we've put the electrode in the right spot and we turn the electricity on, you can see that she's laughing. It's not such a big deal. And as we turn the electricity up, you can see the stiffness gets better. The tremor's better, and the slowness of movement is better. So the reason we do the surgery under local anesthetic is that we need her to show us that we're in the right spot, right? So that's very satisfying from the surgeon's point of view because it's instant gratification. It's what every doctor likes. You've made things better immediately, right? However, one of the research projects that I did during my own PhD degree was to see whether we could find some other way of seeing whether we've done the right procedure or not, whether we've achieved what we want to achieve. And instead of having the patient awake, we would use the MRI scan to see whether our little electrodes were in the right spot, those little black dots, whether they were in the right spot. And the first thing we did is we took patients whose symptoms were so severe, were so bad, that they just couldn't tolerate coming off the medication. So to do the operation under local anesthetic, we have to stop the medication to see how bad the symptoms are, to see what happens when you do the stimulation. But there were some patients, when we took the medication away, they would become so rigid they could hardly move, they could hardly breathe, they got panic attacks. There was no way we were going to be doing surgery with them under local anesthetic. So we used the MRI to guide us, and we looked at the clinical results. And we measure the severity of Parkinson's disease by looking at what we call the UPDRS score. Have you heard of this, or is this too much detail? A bit of blank faces. We measure this with using the Unified Parkinson's Disease Rating Score, UPDRS. And the higher the score, the worse it is. And we looked at patients who we operated on under local anesthesia, and you can see that there's been a good improvement. But then we took those patients where we used the MRI, and you can see there's been an even bigger improvement. So the patients who are worse ended up doing better. And what we figured out was that actually it's a better predictor using the MRI scan to do this than using the patient's symptoms during surgery to do this. And the good thing about this is now we can perform surgery with patients asleep, don't need to be awake. And I haven't come across a patient who was disappointed about that yet. You don't have to stop all your medication before the surgery. You have to reduce it a little bit because we can put you into overdrive unless you do, but you don't have to go through the discomfort of coming off your medication. The surgery is shorter, which means the risks of the anesthetic are less, like developing blood clots in your legs and things like that. It's much less stressful for patients, and actually the recovery from the operation is quicker. Patients go home quicker. So it's a tick on all counts. And these are some of the results. So we publish a lot. I'm an academic neurosurgeon, so I do a lot of research and we publish a lot of papers. And I publish a lot on clinical outcome. And there's a paper that I wrote together with one of the neurologists looking at the outcome of MRI-guided subthalamic nuclear stimulation. And the editor of the journal suggested that this showed an unprecedented risk-benefit ratio, and they are now a benchmark for all other international centres doing this surgery. So this is the benchmark. This is what you have to achieve, right? And we've also published a paper more recently looking at patients' UPDRS, remember, higher is worse, and looking at how things are, not the week after surgery, but 1 year after surgery, and you can see there's an improvement. But we also looked 5 years after surgery, and you can see that there's still an improvement. And then 8 years after surgery, and you can see that there's still an improvement. However, it's slowly going up again, all right? So although the disease is getting worse, you're still likely to be better 8 years after the surgery than you were before the surgery. But it's not a cure, right? This is the biggest problem that we have to face. That's a resin cast of the blood vessels of the brain. So I need to get to where I need to get without damaging any of those blood vessels, right? Because that will cause a stroke and could threaten somebody's life. So it's serious, right? And because of the technique that we use, I wanted to look at what the risk factors were for causing a bleed. So I looked at all the publications on deep brain stimulation for over 10 years, and we saw that if you were older than 75, or if you suffered from hypertension, your risk was higher. Didn't mean it was going to happen, but your risk was higher. If you used certain surgical techniques, your risk was higher. When we looked at the technique that we use, which is called image-verified surgery, we're using MRI to verify that we're in the right spot. If the rate of causing hemorrhage, bleeding, that caused death or disability, because that's the bleeds I really don't want. If you have a small bleed on the MRI, but the patient is fine, that's okay. But if I have a large bleed on the MRI and the patient has a stroke or is dead, then that's what I really care about. And if the rate of those hemorrhages was the same as the rest of the published literature, we should have seen 7 deaths in our 700 patients. In fact, we saw 0, right? So this tells us, and if you do a statistical test, this tells us that our way of doing the surgery is much less likely to cause death or disability because of a bleed. And to date, I haven't had a single patient who's had a bleed, who suffered a stroke, or lost their life because of that. And I hope it remains that way till the end of my career. So what should you expect after having DBS surgery? Well, the first thing is have realistic expectations. I say it again, DBS is not a cure for Parkinson's disease. If you're looking for a cure, look towards that man over there. So Neville and I were at medical school together, and what Neville is looking at is he's looking at those abnormal folding proteins and seeing whether there's a way of stopping those proteins from folding badly and continuing the progress in disease. And I look forward to him making me unemployed so I can retire. It can take time to achieve a balance between medication and stimulation. If you've had Parkinson's disease motor symptoms for 10 years, and today you've had surgery, don't forget that before those 10 years you had another 20 years of problems accruing, and after the surgery we have to find the right dose of medication, we bring the medication down, and the right dose of stimulation, we bring the stimulation up, before we find the best balance. So if it takes us a few days or a few weeks to do that, bear with us. It's not a light switch where everything's better from day one. It's not painful surgery. It's not comfortable, but patients are up and about, out of bed the day after surgery, right? And it's very important that you do that because we don't want you lying in bed getting blood clots. And this is very true before the surgery. We don't want you lying in bed before the surgery because you're more likely to get blood clots if you do. The risks of surgery are small, and it's my job to make those risks as small as possible. But there is no such thing as completely safe neurosurgery. Okay? We've talked about the risk of bleeding. So far it hasn't happened, and I think that's because of the way we do the surgery. There's a small risk of infection. Whenever you put a foreign body in the body, whenever you put metal or something else in the body, if one bacteria, one bug sticks to it, then that bug can grow because there's no blood supply in the metal to fight that infection. So we're very strict about reducing infection. We tell patients to have wash with medicated shampoo and medicated soap before surgery, and we use antibiotics before and after the surgery. The risk of having infection in my hands is about 1 or 2%, right? Malala?
I made a beautiful
and I've been with Parkinson for 5 years or 6 years now. And the only thing is mind walking and traveling. No tremors, nothing. As it was a bit of depression.
Well, I'll tell you what, why don't we have a chat after here rather than having a public consultation? Should we do that? I promise I'll come and have a chat with you afterwards. Okay? So we talked about infection. Seizures can happen whenever you touch the brain. Accessione it. Again, it's very unlikely that you have these, and I've never had anyone who's had multiple seizures that we call epilepsy as a result. But if you do have a seizure, especially in England where the laws are very strict, I don't know what the laws are like in Malta, you can't drive for 3 months until we know that you're seizure-free. Around the time of surgery, you can have a change in mood, especially if you've had problems with the medication. Remember, the surgery has a similar effect to the medication. And when we put the electrode in, we can cause a bit of swelling around the tip, and we don't have a lot of control over the swelling. We just have to wait until that swelling dies down. And some of the side effects can be very similar to the side effects of medication. So if dopamine agonists caused you to gamble a lot, we would ask you to give all your checkbooks and credit cards to your partner before you come in for surgery. Right? And if it was the hypersexual thing, we'll give you the male or female nurses, depending what flavor you don't like. You can have problems with speech after surgery. Speech can be affected by Parkinson's disease, but it can also be negatively affected by certain types of surgery. And I'll come back to this because we've done a lot of research into trying to minimize that effect. These are just a couple of patients that we've operated on in the UK, before surgery and after surgery, 2 years after. And a patient with predominantly tremor, so you can see the different types of Parkinson's disease at the top, and we've done different operations because we're tailoring the surgery for these patients. And this patient over here on the right, his main hobby was playing the piano in his local church. So for him, that tremor was very disabling, and he's been able to go back to that. So we talked about speech. I don't know if you can hear this. I'll put the volume up and see whether the microphone can pick it up. If it doesn't work, we'll move on, but here we go. So there's a patient who's done very well from surgery. His movement is great, but his speech is difficult to understand.
And I drove up to London this time as well for our appointment, so I'm quite pleased about that. It's quite a lot of progress. So I hadn't driven for over 6 years. And so that's a definite improvement.
Can you hear that? So he's actually saying there's a definite improvement. He hasn't driven for over 6 years, and now he can drive. So but his speech is not clear, right? And there was a clear deterioration in his speech. His speech wasn't good before surgery. Yet we have other patients, and this is a patient before surgery.
I'm cutting the whole thing very short. He said, David, which one of these animals live in its head? An otter or a cuckoo?
Okay, so you can hear that she has a freezing and hesitancy in the voice, a bit like when you get stuck and can't walk. And then 3 years after surgery, without medication, this is her speech.
It's my 1 minute speech, which I was totally unprepared, but I guess I could talk about the Sheffield Film Festival, about which I know absolutely nothing, except that Michael Francis, who directed...
Right, so one patient's speech is worse after surgery, and the other patient's speech is better. So one of the things we asked ourselves is, why is this? So we went back to those MRI scans that we did, and we noticed that within this little structure, this little black thing called the substantia nigra, if our electrode was here, you were more likely to have speech problems. If our electrode was 2 millimeters away, you were less likely to have speech problems. So instead of just aiming for the subthalamic nucleus, we now aim for the back half of the subthalamic nucleus. And if we looked at what happened before we did this, the deterioration in speech, this is our speech and language therapist, by the way, who I was working with, the deterioration in speech is 16% if you measure the amount of words that you cannot understand. After this 2 millimeter change in targeting, the deterioration of speech is now 2%. So this is the way that we do research to make things better as the years go by. So these are the last couple of slides, okay? What are the new challenges and potential advances in surgery of Parkinson's disease? Well, there are new types of hardware coming out. Rather than having a battery that you put in and then it depletes after 4 or 5 years and we have to change it, we now have rechargeable batteries coming online, where you put a battery in, you plug a device in the wall. Once that's charged, you put it in your pocket, and it charges through the skin, just like some mobile phones charge when you put them on a plane. And these batteries can now last up to 25 years. So this sort of battery stops us from having to do repeat operations. There are other companies that are producing batteries that you can make a small hole in the skull, and you put the battery in the hole in the skull so that you don't need to have any batteries over here. So it's cosmetically better. That's not available yet, but they're coming online. Something that we're contributing to in London is that at the moment, we pass an electrical current through the brain all the time. It's called an open loop stimulation, right? What we're doing in London is we're measuring the electricity of the brain, finding the signal that's causing the symptoms of Parkinson's disease, sending a small impulse of electricity to the brain to block that abnormal signal, and then waiting until that signal comes back before we put more current in. So in other words, we're only stimulating the brain when the brain tells us it needs stimulating. And this is a closed loop because we're getting feedback from the brain itself. And what we're finding in our first studies is that we can use half the amount of energy and get twice the amount of effect. So this is a win-win situation. So at the moment we're miniaturizing this technology, because at the moment it's only done when electrodes are first put in and externalized to a big computer. Now we're miniaturizing that technology so we can put it in the battery, so that hopefully in the years to come we'll have that better technology available to us. We're looking at different areas of the brain to treat different types of symptoms in Parkinson's disease. So one of the trials that we're doing at the moment is placing electrodes in a part of the brain called the nucleus basalis of Minert. And what this does is it has lots of neurons that are involved in the cognitive problems that we can see in very late Parkinson's. So we're seeing whether we can use this therapy to help patients with Parkinson's disease dementia symptoms. Whether it will work or not, I don't know, but we're currently doing a trial in the UK to see. Or targeting a nucleus called the pedunculopontine nucleus. It's another part of the brain where we hope to help these patients who have particularly gait problems, and mostly that freezing of gait that can be very difficult when you're in crowds or going through doors. Again, watch this space. We don't know whether it will be effective or not, but we're exploring that. Further down the line, different groups are seeing whether we can put growth factors in parts of the brain to stop those nerves from dying. So we're trying to give these nerves little chemicals that will prevent them from dying. So this is a therapy that's trying to slow the progression of the disease. Or using gene therapy to alter how the brain, those nerve cells process information inside the nerves, again with the aim of preventing those cells dying. And then finally, there are some groups using cell therapy, where they take dopamine cells from a petri dish and put them in the brain in the hope that they will provide enough dopamine through the brain. These last ones are at the moment pie in the sky. They are research projects. We don't know whether they're going to work or not. Okay? So, in conclusion, deep brain stimulation can significantly improve symptoms and quality of life in selected patients with Parkinson's disease, but it's not a miracle cure. There is a risk of serious complications, but in experienced hands that risk is very low. Deep brain stimulation is not a switch, it's not an operation, it's a lifelong therapy. And the future challenges that we face is treating these non-motor symptoms, both of cognition, higher mental functions and mood, looking at neuroprotection to slow the disease progress, and looking, if we could, at neural regeneration. But these are decades down the line. So I couldn't end this talk without thanking the team of people that I work with in London, particularly my mentor, Marwan Harris, who's been very generous to me. And also over here, the team that I work with in Malta. And that's the very first DBS operation in Malta. And I'd like to thank everyone from that team, but particularly Josanna Aquilina, who's the neurologist that I work with, who I couldn't do what I do here without her dedication to patient follow-up in terms of progress. So with that, I'd like to thank you very much for your attention, and I'll take any questions.
talk. So we've got some time for questions. So fire away, Mr. Zrinzo's here. We won't get this opportunity
I'll be
this
back.
often, so we'd love to have you back. So if there's anybody who'd like to ask questions, please go ahead.
Are stress and anxiety related?
So we know that stress and anxiety can make symptoms worse, definitely. But we don't think that stress and anxiety can cause the disease. Very often patients tell me that they're going through a very difficult time of their life, and that's when the symptoms appear. But we know that the iceberg is just below the surface, and stress, or a period of stress, moving house, a bust up with a relationship, problems at work, can make that worse. So just to give you an anecdote about that, I've got two patients with very similar symptoms. They both have left-hand tremor, and they're both right-handed. So the left-hand tremor is only a social thing. And one of them has retired. He's 60, but he's minted. He's got a lot of money, and he's retired, and he likes going to the pub, and when he's relaxed with his mates, the tremor isn't a problem. And when he becomes a little bit stressed, the tremor comes out, and he jokes about it, right? I have an identical patient who's a company manager, right? And he's still working at 60, and he's very keen on keeping working. And every time he gets up to give a talk in front of his employees, the tremor goes like mad, and he can't control it. And I tell these people, look, you have the same symptom, but the first one doesn't need surgery, because he's very happy. It's the same symptom, but the quality of life of the first patient is perfect. The second patient can benefit from surgery, because his quality of life is not the way he wants it to be. So his option is either put up with it in your job, or leave your job if you can to another one or retire, or have the surgery to try and help with the tremor. And the decision is his. In fact, he ended up having the surgery and he's gone back to work. So I thank you for that question, because it's given me the opportunity of showing that the surgery is not one solution fits everyone. You can have two patients with exactly the same symptoms, right, who need very different approaches. Does that answer your question? One second.
The well-known actor Michael J. Fox,
Yep.
He mentioned one thing which was quite interesting, that he was liking ice hockey.
Mhm.
And when he played,
Mhm.
the tremors that he had
Went away. Yep.
But then, after he calmed down,
Yep.
they come back.
Yep.
Why is that?
So we see this not only in Parkinson's disease, but in many other movement disorders. When you're really relaxed and really enjoying yourself, the symptoms go away. And one of the best examples is dystonia. So dystonia is a similar type of movement disorder. It's not a degenerative condition. And I have one patient who tells me, look, I go to work and I'm dystonic, and I sit in front of the TV and I'm dystonic. I go fishing, and all the symptoms melt away. And it's a very good question, and the best answer I can give you is that the way that we control movement differs in different ways. And automatic movements are very different from movements that are planned or movements that require some attention. So one of the classical examples, you may have seen the film Awakenings, which is the discovery of dopamine, and in that they mention that you can have a ward full of catatonic Parkinson's patients. Catatonic, by which I mean they're frozen to the spot. They didn't have dopamine. If you shout fire, they'll all get up and run out of the building, because they're accessing a different way of moving their body. They're using different circuits that are still preserved. And I suspect that that's what's happening with Michael J. Fox. When he's particularly enjoying something, then those symptoms, it's the opposite of having stress that brings out the tremor. When you're relaxed, your symptoms get better. Hello.
If within a family there are different members who have familial or essential tremor,
Right.
can that gene change to Parkinson's somewhere down the line?
Okay. That's a very good question, and one that academics are still arguing to this day. So essential tremor, for those of you who don't know in the audience, is a different disease from Parkinson's disease. But there are some patients with essential tremor who eventually develop Parkinson's disease. And we think at this moment in time, the best evidence is that they are different diseases, but if you have essential tremor, you have a slightly increased risk of developing Parkinson's disease. but that risk is very, very small. So it's not something that an individual should worry about, but from an epidemiological point of view, when we're studying cohorts of patients, because of that slightly increased risk, we think that, you remember I told you that most patients with Parkinson's disease don't have a monogenetic form. There's a number of genes that interact together with the environment. And if we can find those genes, it's likely that the multiple genes that can lead to Parkinson's overlap with the multiple genes that can lead to essential tremor. Am I a little bit, does that explain it a little bit? Have I answered your question?
Yes, I've understood.
Very good. Hi.
Is there a drive towards opting for surgery earlier on in the natural progression of the injury rather than just waiting for the medication to fail?
I think that's a very good question. I take issue with very early surgery in Parkinson's disease. I don't think we should be doing surgery very early on in Parkinson's disease for two reasons. One, very early on in Parkinson's disease, you're never quite sure whether it's Parkinson's disease. There are other types of Parkinsonism that can masquerade as Parkinson's disease, but then end up being something else. So if you operate too early, you may end up operating on patients who you should not have operated on. One. Two, safety is my bugbear. I am absolutely insanely meticulous about safety. I would much rather I did an operation the patient was no better than I did an operation the patient was worse. Right? And I think doing an operation when a patient is doing well in life and exposing them to a small risk when there's no need to expose that patient is ridiculous. Having said that, I think that at the moment we probably operate too late. In other words, patients have been suffering for many years unnecessarily because they could have got benefit early on. So at the moment, if you look at the literature, we operate on patients about 13 years after they first develop the motor symptoms. I think that possibly we should bring that down a little bit, maybe to around 7 or 8 years, but not to 3 or 4 years. But like I said with the example here, there isn't a question of how I should wait 5 years and then do the operation, or I should wait 8 years and then do the operation. The question is, how are you, the patient in front of me, coping with life at the moment? If you're coping well, don't do the surgery. If you're beginning to struggle, then do the surgery. If you're struggling a lot, then we can do the surgery, but it's a shame we didn't do it before because you would have benefited from 2 or 3 years before. So that's my rationale. When you're beginning to struggle with medication, that's the time to think about doing surgery. Does that answer your question?
I'm sure. Does it have a neuroprotective effect?
That's a good question too. The chap who popularized STN-DBS is adamant that there's a neuroprotective effect of DBS. I've looked at the literature. I don't agree with him. Was that a question?
Yes. Mine was rather similar to this guy. It's a question of when.
When to do the surgery?
There's no age or...
There's no absolute age limit. There's no absolute age limit.
Rather with lifestyle or struggling.
Yes. I think it's a... So I don't think I have an easy question because it's a tailored question. I think we should tailor that answer to the patient. I think it's the patient who should decide when surgery is right for them. You can have two patients with identical symptoms, and one doesn't need the surgery because he's very happy with those symptoms, and one really wants the surgery because those symptoms are the bane of his life. So it's a very difficult question to answer, and that's why I kind of put you off a little bit, because you need to have an in-depth consultation, an in-depth discussion for me as a surgeon to tell you, listen, your aims are realistic, let's do it, or to tell you, listen, your aims are unrealistic, you shouldn't be doing it.
Or some kind of indication. Like, it's still time. You started, let's say, 3, 4, 5 years with medication.
Yes?
Rather than asking when, because when it's like we discussed, is there an indication?
If you're doing well on medication, 3, 4, 5 years with medication, you're still doing well, and you're still doing what you want to do, whether it's your job, whether it's your family life, whether it's your hobbies, then you really don't need surgery. If you're struggling with your hobbies, with your family life, with your work, and however much you change the medication, you're still struggling, then you should think about it, even if you're beginning to struggle, right? But you shouldn't do surgery if the medication can achieve that for you. And that level is different for different people. Some people can tolerate a lot of symptoms without feeling unhappy. Some people can tolerate very few symptoms without feeling unhappy. So it's difficult. If you're asking about a particular individual, I'd have to sit down with that individual and discuss with that individual. It's difficult for me to give an exact answer because there is no exact answer. Does that make sense?
It's tailor-made.
It's tailor-made. That's perfect. Perfect. Custom-made. It is. It is. That's the job of a doctor. The job of a doctor is to take the science and to take the patient and to explain the science to the patient in a way that they can understand so the patient can make a decision.
Are you doing the surgery in Malta?
Sorry?
Are you doing the surgery in Malta?
Oh, yes.
And how can you get the appointment in these things?
So the person I work with is just Dr. Aquilina, Suzanne Aquilina, and I see patients with her every year, usually around the Easter time, And then if patients are suitable for surgery, we usually schedule patients for around the summertime.
So you have to fix an appointment with Mrs.
Dr. Aquilina is the best way through, and that's all on the NHS, that's all through the government. Hi.
This is a progressive disease. Is there any particular time when it is too late to have this
To have surgery? So the answer is unfortunately yes. So there are some times when I think the risks of having the surgery outweigh the benefits. And I mentioned a few during my talk. If the disease has progressed to the point where there is the beginnings of dementia, then it's probably not a good idea. I might still help the movement, but I may make the cognition, the thinking, worse. And that's, your thinking is the most important thing. It's even more important than the movement. There are some patients, so as I said, I've operated on patients in their 80s, right? But some patients in their 80s are very robust. Other patients in their 80s are very frail. And every operation we do is a type of trauma, right? An operation is trauma, it's a controlled trauma, but it's a trauma. And we have to make sure that that person can withstand the trauma with a likely chance of doing well. So there is no absolute age limit. Absolutely there isn't an age limit. But the risks do slightly go up as you go above 75. And then the job of the surgeon is to balance those risks. And I would much rather not make somebody worse. I would never take risks that are too high. And I would only take risks when I think the likely benefit is very big. May I take that one first?
I'm new in this thing.
Welcome.
I didn't wish to join you. Well, I'm not very knowledgeable about it. It's all I know is that we've got lack of dopamine.
Correct.
It shrinked or went away.
Correct.
Does the science does not produce this kind of stuff?
So a lot of the medication that we give is actually a precursor to that dopamine. So the tablets that work very well in Parkinson's disease help the brain produce more dopamine. And if those tablets are working, then that's what you should do. But when those tablets stop working or have bad side effects, then there's something else we can do. We can't make the brain produce more dopamine effectively at the moment. People are trying, and that's what the stem cell transplants are for. Some people are putting dopaminergic cells into the brain to try and encourage them to make more dopamine. Some people are putting growth factors into the brain to encourage those cells that are left to produce more dopamine. But so far, there's no hard evidence that this is beneficial to patients. But what we do know is that by putting a small electrode in a different part of the brain, we can change the effects of the lack of dopamine in a way that's positive to patients. And that is hard scientific evidence. So we know that deep brain stimulation works very well in certain patients, and we're trying to see whether other approaches might work. But one is clinical practice, it's established. The other is research. We would only do that to try and see whether it works. Does that answer your question? Good.
Quick question. As you tend to lean surgery,
Mhm.
how would you tell, let's say, people about preventing Parkinson's disease?
So at the moment, we don't know how to prevent Parkinson's disease. I would very much like to find a way of preventing Parkinson's disease. And like I said before, I was at medical school with this gentleman at the back, and we've almost gone away because I've gone and I live in London, and Neville's gone and he's come back and done research. But we're tackling the problem from different levels. So Neville's trying to tackle the problem from the molecular level to stop the build-up of this beta, the misshapen molecule. I'm tackling the effects of the disease. So at the moment, I'm in a position where I can actively help patients. Neville, unfortunately, isn't in that position, but his goal is very noble, which is to put me out of a job. And that's perfect. I'm very happy. I'm very happy. I would be the... So another thing, an anecdote. I say that really reasonably. So you remember Irving Cooper, who tied off that little blood vessel, right? He was operating on thousands of patients. His livelihood was operating on patients with Parkinson's disease. When he saw one patient take dopamine, he stopped operating on Parkinson's disease for a year. He said, I will not do another operation because this means that I don't need to operate. And he only restarted operating when he started to realize that actually some patients couldn't tolerate dopamine because of nausea and vomiting. So this guy was not only a doctor, not only was he a humanitarian, but he had ethics of steel. He's not, and this is America where they charge for every operation, right? So if he puts me out of a job for Parkinson's disease, I've got loads of other things I can do with the neurosurgery. That's not a problem. I'd love for him to put me out of a job. Sadly, I think I'm going to retire before he does, but I would love for you to prove me wrong. Does that answer?
Yeah, thank you.
I'm aware that Parkinson's affects everybody differently. However, in the case of early onset, could it be that it doesn't, maybe I'm being a bit positive here, but that doesn't progress too much, that the symptoms never become very, very bad? Or
So,
just it's restricted to a tremor or slight rigidity?
So when you have early onset Parkinson's disease, it's more likely that there's a single gene that's the cause of that. That doesn't mean that it's definitely the case. That's the first thing. Second thing is there are different genetic problems that can cause an early onset Parkinson's disease. So there are at least 15 genes that I could mention to you now that cause early onset Parkinson's disease. And different genes tend to progress at different rates. But even if you have a gene and you know what gene is causing your early onset Parkinson's disease, no doctor can sit down and tell you this is when you're going to have more problems. Everyone's an individual. And the likely reason for that is that although one gene is having a lot of an effect, there are thousands of other genes that have an effect as well. So they're living in amongst a population of other genes. And there are environmental factors to boot that we don't know all about. So, for example, pesticides is one environmental factor we know about. People who work with pesticides have a slightly increased risk of developing Parkinson's disease. People like farmers who develop with pesticides. So predicting the future in such a way as what you're saying is not possible with our current technology.
However, I'm sorry to interrupt you. Generally, are there some cases where they don't progress, or doesn't everybody?
No, so it tends to progress, but people tend to progress at different rates. That's right.
When you say pesticides, is this what we spray on to kill insects?
No, this is usually industrial scale of pesticides. I wouldn't be worried about using a pesticide. You're working day in, day out with them. That's the type of exposure. Hello? Hello. I can't tell you from a tete-a-tete discussion like this. We'd have to meet, we'd have to discuss, I'd have to examine, you'd have to look at tests. So I'd very much, the two ladies in front, I'd be very honoured to meet you together with Dr. Aquilina and to go through things together. But it takes me at least an hour, and there are some people in the room who I have gone through this process with, to examine, to look at the facts, and even then I may require more tests and things like that. So I would love to answer your question, but this isn't the forum for it. Yes, and it's up to you.
But you did mention falling down because
Yes,
you
yes,
drag
yes,
your
it's in
leg.
balance.
Absolutely,
It's imbalance.
absolutely. Walking problems with balance and walking can be a problem with Parkinson's disease, but I can't tell this lady that until I've examined.
No,
It could
no,
be
no.
due to many
No,
other.
no, I'm not referring to
Lady at the back.
Is there any food, like
Yes,
nutrients,
That one can take.
which can help?
There is no evidence, sadly, at the moment that one particular type of nutrient makes a beneficial effect on Parkinson's disease. The advice I can give you is to eat a healthy, balanced diet, but that's just for general health, not necessarily for Parkinson's disease. The two things that we know are protective somehow are caffeine and smoking. The problem with smoking is that it may reduce your risk of Parkinson's slightly, but it increases your risk of cancers hugely, so I would definitely not do that. And the problem with coffee is that all the studies that have been done have looked at coffee drinkers before they develop Parkinson's disease, not whether coffee, when you have Parkinson's disease, slows the progression. It seems like a rational thing to say you'll drink coffee to prevent progression, but there's no evidence that that helps.
Nothing which can help the gut.
Sadly not. You can help the symptoms, but not prevent the progression of the disease in the nerves in the gut.
And what about the nose? I mean,
The sense of smell.
yeah, I mean, what happens to the nose?
So
The sense of
one of the theories that people have come up with is that it's an interaction between the genes that you're born with and environmental factors, and that's why it's the nose, because it's very open to environmental factors, and the gut, because it's very open to... But we don't know what those environmental factors are, and we don't know the genetic combination that exposes individual patients. There's a lot of research going on in this, but this type of research doesn't tend to benefit individual patients. It tends to improve our understanding of what's happening, and if we get a clue from that, it might help Neville understand why the protein is folding in a different way than it should. So that's why we do all these population studies, to try and understand what's driving the disease, because once you understand the mechanism, you might be able to block it.
When you mentioned the gut, does that involve also changes in bowel movements?
Yes, so
Not
very
just
often...
constipation.
Constipation is the commonest type of presentation, but people have different...
You are
again,
accustomed
Mhm.
to leave at a certain time of
Time.
the day, and then you suddenly, not suddenly, you tend
Sudden
to change.
changes are unlikely to be due to Parkinson's disease. You should always seek advice if you have a sudden change in bowel habit for other reasons than Parkinson's. But sudden changes, Parkinson's doesn't act suddenly. It's a slow process. Yes, the side effect of, it's often side effects of medication. There was a question from the back? Oh, sorry. Hello, ma'am.
Hi. Could you mentioned something earlier on about that about 70%, that it's after 70% that the symptoms start.
Oh, so you can lose...
repeat what the 70%
So,
was? Or I didn't understand.
so there's a type of cell in the brain. Little fast reflexes. There's a type of there's a type of cell in the brain that forms what we call the substantia nigra. That is Latin for the black stuff, and that black stuff produces most of the dopamine that we have in our brains. And what we found is that patients who present with movement problems and Parkinson's disease have lost 70% of those cells. In other words, you can have the disease for many years, lose 40, 50% of those cells, and you have no idea what's going on. And that's because nature is very good at dealing with slow changes. So we have the beautiful saying, it's the straw that breaks the camel's back. You can keep loading and loading and loading, the camel will take it until you find the last bit. And that's what biology is very good at adapting, until finally it can't adapt anymore. So the brain adapts to all this loss of neurons, until finally it can't adapt anymore and the symptoms come out. And if you're going through a stressful phase, the brain can't cope with that in addition to it. So people say, this is the stress that brought it on. No, it's the stress that revealed the problem. The problem was there. The stress revealed it. I think I've actually exhausted all your questions. Oh no, bar one. Go on. Excellent question. So sleep disorders is part of Parkinson's disease, and sleep disorders are also part of other types of conditions, neurodegenerative conditions. And shouting out while asleep is well recognized in related conditions with Parkinson's disease, but can also happen in Parkinson's disease. It's more likely to be an effect of the disease than of the medication, but there are rare patients. It's more likely to be an effect of the disease than the medication, but there are rare cases where it can be an effect of the medication. So if it happens, you need to speak to the neurologist, because they may adjust the medication to see whether they can stop that. And if that doesn't work, they may add different types of medication to help with that. Because one of the problems with Parkinson's disease is problems with sleep. Now, if you don't have Parkinson's disease and you're well and you don't sleep properly, you're shattered in the morning, let alone if you have Parkinson's disease and you don't sleep well at night. So another good thing about surgery that medicine doesn't help with that much is that when you're asleep, you can't pop pills, whereas with surgery, you have the surgery on, the stimulation on all the time. You can turn in bed, so you're not stiff in the morning. You can go to the bathroom more easily, and therefore you tend to get more rested, and therefore there's that beneficial effect of actually waking up rested rather than knackered.
Thank you very much.
Thank you all.